34-year-old female, several months of pressure in her head, and 2 weeks of severe headache prior to her admission at hospital. Neuroexamination at admission, bilateral papilledema. This is her preoperative imaging workup. We have CT scan here. It shows a very big, large tumor in the ventricular region and hydrocephalus. Here we have MRI axocut showing the same tumor arising on the located at the left lateral ventricle, occupying mainly the body, maybe a little bit anterior to foramen Monroe, part of it, and a little bit posterior, the transition between the body and the atrium on the left lateral ventricle. You see the septum pellucidum over here. So this tumor belongs to the left lateral ventricle. And here we have the coronal cuts of her preoperative MRI showing the tumor on the left lateral ventricle. But the tricky part of the surgery is at the lower part of the tumor removal, we have to pay attention to this. What vein is this? This is thalamus striate vein draining into the internal cerebral vein. So we have to preserve these veins. For me, this is the tricky part, the most dangerous part of the surgery. Obviously, the tumor is big, but for me, the most dangerous part of the surgery is in this area, the lower part of the tumor. This is the sagittal cut of her preoperative MRI. And you can see clearly that the tumor occupies more the body of the lateral ventricle and not the frontal horn, maybe a little bit of the atrium. And I have planned this kind of craniotomy, so it allows me to reach for the most posterior part of the tumor and also to reach the most anterior part of the tumor. And I was planning a small callosotomy. So this is my surgical planning. So she will undergo a left frontal craniotomy, inner hemispheric transcallosal approach. So this is a positioning of the patient. This surgery was performed in 2011. So at that time we shaved the most of the head. We don't do that anymore. We preserve most of the hair nowadays. This is the exposure after the dural opening. So this is the superior sagittal sinus midline, and this is the left hemisphere. Let's go to the video. So the first step of the surgery is obviously to open the inner hemispheric fissure. You can follow the forks. It's not so difficult. And cut all the arachnoids. I like to do this to free the vein by cutting the arachnoid around the vein, because this way I can mobilize, you can retract the brain without tearing the vein. I'm putting gel foam to serve as retractor, so I don't have to use retractor. But in this case, the brain is a little bit swollen because of the tumor and also because of the hydrocephalus. So carefully dissecting, cutting the arachnoid membrane, and replacing the gel foam. As when we gain more space after dissection, we can put more gel foam to keep the space open. Now I'm looking at the corpus callosum. You see the white structure, and we have the left pericallosal artery. So replacing gel foam to keep the space inner hemispheric open. Now corpus callosum, left pericallosal artery. So I have to go to the body of the corpus callosum. I'm trying to gain more space between the corpus callosum and the cingulate gyrus. So I'm putting more small gel film on the callosal sulcus. So now I'm performing the callosotomy from the body of the corpus callosum. Now soon we can see the tumors right here. So I need to gain more space, and after gaining space I have to debulk the tumor, so make it smaller so we can remove it. Now getting samples for the histology analysis. Luckily it does not bleed so much. A little bit bleeds a little bit, but not too much. More piecemeal. Resection, hemostasis, and working in a very tiny space without spatula. And remember that for me there are two parts that are difficult in the surgery. First is to go to reach the lateral part of the tumor. You know, when you do inner hemispheric approach, you're at the midline. So sometimes it's difficult to go from the midline and turn the corner towards the lateral part of a tumor. So the best way is to debulk, empty the center of the tumor. So the tumor most of the times will come to you. The lateral part of the tumor will come to the midline when you debulk the tumor. Another dangerous part of the tumor we saw on preoperative MRI is the lower part, the bottom of the tumor. So we have to be careful not to damage the thalamus striate, mainly the left thalamus striate vein, and also not to damage the internal cerebral vein. Obviously, the internal cerebral vein will be protected by the superior membrane of the tila choroidea. There's going to be additional arachnoid to protect internal cerebral vein. It will be a little bit more difficult for you to damage. But the thalamus striate vein, you have to be careful because it is located at the lateral ventricle. So continue to work on the tumor, debulking the center. At the same time, we remove and also make hemostasis. So try to keep always the surgical field clean whenever possible. And we have to go after the tumor. Luckily, the tumor is very different from the normal ventricular structure. Ventricle is very white. The tumor is very red. It's different. So keep working. I'm not using spatula. So this is the choroidal plexus. A little bit of tumor, but most of it is choroidal plexus. So be careful. And I was checking if there's any residual tumor and removing the clot, cleaning the surgical field, and more tumor over there. And then the final stage of the surgery after the tumor removal, I like to put Surgicel to make hemostasis. This is, you see that even the lateral part of the tumor came to me because of the pressure. So this is the final aspect of the surgery, and that's it. This is the postoperative MRI of our patient. You can see the axial cut here, coronal cut, and sagittal cut. The internal cerebral veins were totally preserved. And also, you see the thalamus striate veins on both sides were preserved. After the surgery, she was confused and disoriented without motor deficit for 5 days, and she had memory complaint and a depression for almost 6 months after the surgery. She resumed her professional activity as lawyer only 1 year after the surgery, and the histology showed neurocytoma. She had no recurrence since surgery, performed in 2011. The last time I saw her was 2020. So after 9 years, there is no recurrence.